Good morning, good evening, and good afternoon. My name is Dr. Mamta Swaroop, and on behalf of the Advisory Board and our newly elected executive leadership, we would like to welcome you to the Association of Academic Global Surgery Fall Assembly. We've come a long way from the initial meeting held in San Diego during the Clinical Congress in 2017. And so before we start, I would like to invite you in participating in a quick survey. In 3 to 5 words only, please let us know why you're present here with us today. Okay, so that's the bit.ly, and I'll just give you a few minutes to complete this. We're gonna show you the results of this towards the end of the session. So it's posted in the chat. As people arrive, please copy this into your formats and just type in 3 to 5 keywords about why you're here with us today. Yes, Dr. Brender, it's so wonderful to hear your words. If you could add those words to the bit.ly, if you can go to that for me, that would be wonderful. And just add those words for me there. That would be amazing. Thank you, sir. Wonderful. Well, we'll have another opportunity to do these. Do this again later if you haven't had an opportunity to go to the bit.ly. Let's talk a little bit about what we have planned for today. So we have some exciting things planned. First, we'll have our president, Dr. Sanjay Krishnaswamy, speak about academic global surgery and our organization. Then we'll have a keynote address by Dr. Sudha Jayaraman. We'll then hear about the work of our amazing committees from Dr. Kristen Long, and then a report from our esteemed treasurer, Dr. Christopher Dodgen. And then we'll have some breakout rooms to discuss topics that will inform the AAGS strategic plan. We'll then end the meeting with time for any questions that you may all have for the executive leadership. Now for our president's address. I'd love to introduce him to you all. Dr. Krishnaswamy is a pediatric surgeon, surgeon-in-chief of Dornbecker Children's Hospital, and a professor of surgery and pediatrics at Oregon Health Sciences University School of Medicine. Dr. Krishnaswamy has played an imperative role in the development of academic global surgery as an academic field through critical scholarly contributions and bilateral partnerships with LMIC collaborators, the promotion and development of AGS within academic surgical societies, and the creation of innovative programs that have perpetuated academic global surgery both internationally and domestically. During his tenure as the second chair of the Global Affairs Committee of the Association for Academic Surgery, he helped to administer the original AAS International Fundamentals of Career Development and Research courses in West Africa. He also created the first AGS abstract category and sessions for the Academic Surgical Congress and created and oversaw the first trainee research award in global surgery for a major academic surgical society. He has additionally led global surgery efforts within the Society of University Surgeons and the American Pediatric Surgery Association. His scholarly work in global surgery has primarily centered on workforce needs and solutions, outlining responsible utilization of technology and process improvement and career considerations in academic global surgery. He has authored many manuscripts, more than 20 book chapters on academic global surgery, contributed to Global Surgery Research Consortium, served as a consultant for international surgical societies, and spoken throughout the world on AGS and initiatives therein. He is also the senior editor for the book entitled Academic Global Surgery in the Success in Academic Surgery series, the first book outlining academic global surgery as a formal field, serving as an early guide for the career of many currently working in our field. Please join me in welcoming our newly elected president, my friend, mentor, and our colleague, Dr. Sanjay Krishnaswamy.
Thanks so much, Mamta, for the introduction. I just want to say that first, I'm really honored to lead the organization as we kind of begin our journey together. Global surgery has made really great strides over the last few decades, from traditional humanitarian-based clinical care to a legitimate academic endeavor that's aimed at reducing worldwide surgical health inequities. As the Association for Academic Global Surgery, our organization is really built around the definition of academic global surgery. And we have defined this as the application of research, education, and evidence-based advocacy towards clinical surgical care in regions of health inequities. The primary goal of this field, as we know, is infrastructure development with delivery of high-quality surgical care to all, whether they're in high, middle, or low-income countries, or whether they're in urban or rural locations. And while this approach has spawned a large body of scholarly work, fruitful individual partnerships with LMIC institutions, and many university global surgery programs, what's remained lacking is a central body to organize and coordinate these programs to improve visibility of common obstacles and opportunities, share effective strategies, and set some common goals for our field. And that's where the AAGS comes in. Therein, our vision is a world where safe, effectively, timely, and affordable surgical healthcare is accessible to everyone. We aim to organize and establish academic approaches in global surgery in order to reduce surgical healthcare inequity. We hope to achieve this by engaging and unifying stakeholders in academic global surgery, both within the institute, within the organization and outside, in order to cultivate and refine the teaching and administration of global surgery programs via partnerships that are bidirectional and equitable, and develop the next generation of compassionate, capable academic global leaders in surgical education, clinical care research, policy, and advocacy. So how did we get here? Dr. Swaroop mentioned it earlier. The idea for the organization was obviously born many years prior, but we held our first loose meeting in 2017 during the ACS. In the next few years, we officially adopted our name. We launched an advisory board and our Rules and Regulations Committee, which did the critical work of drafting the Constitution, which is our governing document. And then over the last year or so, we formed our initial 9 committees. We held nominations for members, and we really began the work of these bodies with newly named chairs and vice chairs leading the way. Since that time, the organization has held every other month leadership meetings across all the committees. We've had our second general membership meeting. We've added 8 more committees. We formed an institutional representative council, and we accepted nominations for and elected initial executive leadership. So that's gotten us to our current state of 179 active and affiliate members, 128 associate members, and 101 student members, for a total of 408 total members across 36 countries and more than 100 institutions represented on this map. This is our roster of our committees, with the ones in blue having been the most recently added just this fall. Our new institutional representative council membership is from 35 institutions, primarily here in North America. And we put this slide up primarily to please tell you to spread the word on the AAGS. There are many categories for membership, and we aim to have individuals from anywhere have many opportunities to join and contribute. Please tell others about the organization and let's all get involved together. This is our initial executive leadership. While you'll hear from most of us today, the two individuals who really keep things running are Kathy Madani as a secretary of the organization and Upasana Pathak, who is our administrative coordinator. Both work tremendously behind the scenes to make the work of the organization complete. This is our current advisory board, and they play a really critical role. Not only are they organizational founders, but they help to keep our purpose and progress really aimed towards true north. So while a lot has been accomplished in our formation alone, the AAGS is poised to really be an important convening body by engaging academic global surgeons and programs in both high-income countries and low-income countries, as well as global surgery leaders within academic surgical societies overall. So what kind of things can we do? I'd submit a whole lot. We can help ensure baseline shared knowledge and therein set common language in AGS agendas. We can help to create minimum standards of quality for true bidirectional programs in academic global surgery. We can create a transportable framework for the academic development of our trainees. We can reach out across disciplines in order to promote integration and alignment of AGS with other global health fields. And finally, we can promote AGS work to move from description towards intervention. And I think, perhaps most importantly, we can encourage pathways for reciprocal innovation so that the ingenuity of our LMIC colleagues is recognized and even serves as a model for HICs. And most importantly, we can really collectively ensure that this field is always steered toward the interests of the populations and providers that academic global surgery finally aims to benefit. There will obviously be challenges ahead, from recognition of our nascent organization to finding a place in the realm of global surgery and global health for this organization, to tackling the individual obstacles which face the work of our committees and their initiatives. Perhaps the most important next things to address is to take all these big ideas and the workings of our committees and really create a cohesive, overarching plan for ourselves that strategically addresses the work ahead and also addresses the AAGS's role in the global community and what that should actually be. To do this, we need to reflect on our own structure of the organization and our intent, and we need to reflect on what the inclusive core values we aim to represent are. Later on in our assembly here, we'll be able to go into breakout rooms where we'll spend a few minutes informing our answers to these questions and really helping to decide the direction of our organization. In the meantime, I am really excited to introduce Dr. Subha Jayaraman as our keynote speaker. She'll be discussing along the lines of what we've spoken of, her collaborative work in calling for an equitable approach to global surgery curricula. Dr. Jayaraman is a professor of surgery and director of the Center for Global Surgery and director of research at the Center of Medical Innovation at the University of Utah in the United States. She has longstanding collaborations on trauma and emergency systems capacity, both with the Ministry of Health of Rwanda, the University of Rwanda, and the National Ambulance Service in Rwanda. She's been funded by the Rotary Foundation, the Fogarty International Center, and the National Cancer Institute for her work in Rwanda. Importantly for this organization, Dr. Jayaraman is a member of the AAGS Education Committee. So Dr. Jayaraman, please take it away. Thank you very much for your time.
Thank you, Dr. Krishnaswamy, and congratulations to everyone for coming together to create this society, which has been a long time in the making. And especially congratulations to, aside from Dr. Krishnaswamy, Dr. Srolik, Dr. Wong, and Dr. Gajan. Next slide, please. I wanted to think about this talk as a series of challenges for us as a society and us as a field. As we aim to formalize this field, what are the things that we need to think about? The first and main thing is definitional, which seems rather silly to think about. But we have to recognize that a lot of the language we've been using for a number of years have been derived from the high-income country setting. That's okay, as long as we recognize that. And the concept of global surgery has origins in high-income country experts traveling to low-income country staff to train and strengthen capacity. And that also has a place as a role in society. But it is a perspective that we need to be aware of. The addition of this academic perspective is important, but it also still doesn't necessarily entirely include other voices. Next slide, please. So whose voices might we be missing? You know, you clearly saw through the map that Dr. Krishnaswamy showed that there are members and partners across the world who are interested in this concept. Is there a megaphone that includes the rural surgeons? Is there a megaphone that includes surgeons who are in non-academic settings? Dr. Novacek Roy, who I really look up to as a leader in global surgery, considers this group of folks the global surgeons who are in practice. You know, a single surgeon in a district hospital with a large catchment area who is aiming to improve the systems of care, aiming to come up with innovations that improve care delivery, may not necessarily be interested in being on a committee or writing a paper or creating an educational program. How do we include those voices? Because at the end of the day, those voices are very critical to who we are and to what this field is. And so how do we make space for those voices and how do we amplify them is a critical question that I think we as an organization and as a field have to think about. Next slide, please. As Jay mentioned, a key part of that is defining who this field is for, who this field is about, and what the values are of this field. Are there ways that we can take next steps that change how we think about organizations like this? Our model right now is very similar to many other societies. But are there different models that we should consider? You know, maybe instead of necessarily individual or institutional memberships, are there mechanisms to create memberships for collaborations that involve and incorporate our partners in any part of the world and can be led, those collaborations can be led by any institution? And is there a way to indicate that equal level partnership and that ensures opportunities for partners from LMICs, from rural settings around the world, to be intentionally recruited to all the leadership positions, to be intentionally setting the agenda for this organization at every committee? Could we think about collaboration representatives as opposed to institutional representatives so that we, again, amplify those long-standing bilateral partnerships that really focus on work that is equal level as opposed to highlighting specific institutions? Are there steps that AAGS could take, such as, you know, simple things like encouraging adjunct appointments for LMIC partners? How can we amplify their voices? How can we recognize their participation and their critical role in this space without speaking for them? And I think that that's a question we need to really think about. Next slide, please. Well, once we decide who should be in this field and what voices we should be listening to and prioritizing, we need to think about what are the fundamentals of global surgery. Does this include clinical concepts? Does it include academic concepts? Is it about traveling from one place to the other? Are you a global surgeon if you go from Botswana to Peru, or vice versa? And taking that step is something that we also, again, need to think about as a society leading this field. Next slide. One project that several of us started about 2 years ago now, that we just published in the Journal of Surgical Research, was are there competencies in global surgery? Who's published about this? What have other people thought about as critical core fundamental concepts that people who are interested in this space need to know about? And we started out just doing a literature review and trying to see, is there consensus around fundamental competencies? And are these aligned with existing competencies in medical education, surgical education, global health, or not? Or are there missing concepts that are not covered by those that we need to think about that are specific to global surgery? Next slide. This is the paper that is available online, and please do email me if you'd like a copy, and I'm happy to email it to you. And as you might see, a wide group of people from around the world participated in asking this question and saying, well, what is our current status, and how should we move forward in establishing fundamentals for a curriculum? Next slide. In looking at that, looking at the literature to answer that question of what existing competencies there are, first of all, there weren't that many papers that even talked about competencies in global surgery. And those competencies, or those papers, didn't mention some competencies that we thought were actually really important, like health, equity, and social justice. Only 2 of them even talked about social and environmental determinants of health. Which are obviously critical shortcomings that we would want to incorporate in any future framework going forward. Next slide. There are also gaps in many of those papers. Many of them didn't think about or address explicitly essential aspects of surgical systems, whether it is disease burden or resource availability or perioperative care, anesthesia availability, nursing, and pharmacy. All of these other critical aspects of delivery of surgical care. In part because a lot of these different programs and papers that we reviewed were from specific institutions and didn't necessarily have a wide variety of experts across diverse settings contributing to their development. Next slide. And most of them were created in and by high-income country institutions and geared for high-income country trainees and departments and institutions, and focus really on travel and care delivery and preparation for travel. Although many of them included prioritizing LMIC perspectives, several included direct exchange between students, it was still largely a high-income country gaze when you look at the output of all of these papers. Next. It was also interesting to see who had access to this literature. And we went through all of the databases across the continents, across the Latin American continent, across the African continent, to be as broad as possible in finding this literature. And yet most of the papers that we found that discussed competencies in global surgery were actually not available to the majority of people who would be interested in it. And it also highlighted that there are very few global surgery education programs that are led and headquartered in LMICs. I've listed a few programs from the African setting that are great leaders now, but there are not very many of them. Next slide. So now what? So there aren't any universal competencies. There are gaps in the existing curricula. There's an orientation towards high-income countries, and the content is not accessible to most people who would be interested in it. So really, then the next question for the group of co-authors of that paper was really what do we need to do to create universal global surgery competencies? And how do we do that by prioritizing the voices of LMIC experts? And how do we include the missing principles from health systems and public health and reflect the core values that many of us can agree on for the field of global surgery? And how do we then take that forward to create open access curriculum that anyone can access anywhere? Next slide. first of all, we formed a small independent task force, independent of all major surgical societies, in part to ensure that no one group had ownership of this idea or had any force that could be exerted to bias any part of this. And then decided to, through this task force, identify experts across different fields with taking into account geographic diversity, and then develop a snowball sampling of respondents from this initial list. And a few of us through the Operation Giving Back Education Committee have been coordinating and supporting the process. And so far, what we've been able to do is create a draft set of competencies and look at what objectives we should include, whether they're relevant to novice or advanced learners. And we've taken this draft and had the task force critique it, tear it up in every way possible, and then decide on something that the group can agree on as an initial draft. And that's been sent out, that language has been sent out for consensus across the wide, diverse body of participants we've sought out. Next slide. For now, we've had a 50% response rate of 160 people that we've reached out. 60% were from LMICs, or are from LMICs. And for the most part, these are the competency areas we've identified as being valuable to start out with. Each of them has objectives below it that focus the area for the learner, and then identifies whether this concept should be learned by all people who are interested in global surgery, or the ones who are expressing long-term career interest and who are advanced learners in it. And that's the process that we're in sorting out right now. Next slide. So we're aiming to conduct 2 more rounds of iterative surveys to finalize these within the next 2 months, so that they can then be a foundation for curriculum development. We aim to have this published in an open access journal so that everyone can see it and use it as much as is possible. But then there are still areas for further work. Using this to create an accessible basic curriculum and hosting it online is a major next step. And that's an area that AAGS or members could participate in. Creating assessments for the learners who are working to learn these competencies is another question. We would need to develop that. We would need to validate competencies and then figure out how to update these competencies over time. As different programs adopt the competencies and create different curricula, what lessons are they learning? How can that collective knowledge be incorporated into subsequent versions? There's been some discussion among our group about keeping an independent body to review the data and update the competencies, so that, again, this is not beholden to any one surgical society in any one country. But certainly AAGS as an independent body, not specifically linked to any surgical society around the world, could potentially have that role. Next slide. Well, once you have a curriculum, once you have some competencies and a curriculum, you actually have to train people. So how do you finance training? We need to think about new and sustainable models of financing training for both US and LMIC trainees. Not being an expert of the UK, European, or Australian model, I'm not going to talk about that, and that's an area that we need to think about. Other members can contribute towards. But for the most part, training certainly on the US side is very expensive, and for the most part, the US institutions have been focusing on US trainees. And so how do we ensure that LMIC trainees get the opportunity to train in this field? And how do we, as a society, engage in addressing this? Next slide. I don't know if many of you caught this paper that was published last year in BMJ Global Health. It looked at master's programs in global health worldwide. where they were headquartered, and how much they cost. It turns out the majority of the world does not have access to global health programs, which is pretty stark. There's no specific Masters of Global Health program in the continent of Latin America. There's one in Africa. There's none that is specifically dedicated to this in India. And so this is a major problem. This is people creating curriculum, but not actually involving most of the world. And so if you think about what global surgical programs are like, they're very much the same. No one has put this on a map, but everyone can see that that's a likely parallel over time. Next slide. So what does that mean? How do you then keep that inaccessibility or lack of accessibility in mind? Could we create a free online course that is available? That's a basic course that is available to all members or trainees through our organization. Are there ways to ensure that our LMIC partners and colleagues, rural partners and colleagues, can lead through AAGS by discussing their works in a regular, perhaps monthly basis that rotates across each member's institution or partnership? Are there ways that we can work together, perhaps in a consortium approach, to create training programs for US trainees, to have multiple institutions working together with American College of Surgeons or AAGS to create fellowships? We're in the process, University of Utah and another institution, to see if we can create an inaugural global surgery fellow at the American College of Surgeons, Operation Giving Back, and working out the finance of how to do that, and how to have a shared person who's going to be working on ACS global surgery work year after year. Could we create something like that through AAGS? And that's the concept that we need to think about. And how do we ensure twinning with LMIC trainees? How do we ensure peer-to-peer learning and greater involvement and support for trainees, including funding for them? As we create fellowship programs, and as we move forward with creating a consortium type model for fellowships, ensuring that part of that funding goes to an LMIC partner trainee will be an important commitment to equity. Next slide. Next slide. The last two challenges focus on systems. We don't function in a vacuum. We have to function with other clinicians, other professions. And unfortunately, in the last year and a half, we've seen the effects of that disruption. And we need to think about what this surgical infrastructure looks like, the surgical ecosystem that was first conceived by Dr. DeVries and Dr. Price as a system that really expands not just across the clinical fields, but really across other aspects of the health system in the community, whether it's sterile processing or pre-hospital care. All of these things are part of the system that is needed for surgical care. Next slide. But a lot of this has been disrupted, and this is one example. Many of you may be aware of this group called COVID Surge, which is a collaboration led, or at least headquartered in the UK, but is a group that is across dozens of countries, working together to gather information from a wide number of institutions to assess care delivery across the world. This group has published a number of different papers. This one in particular I'm highlighting because it gives us a sense of the impact of the last year and a half on surgical care, and especially surgical care for cancer. And that impact is largely on LMICs. And we all know, if you've ever had surgical exposure to surgical oncology, that relies on a system. It relies on multidisciplinary tumor board. It relies on radiation. It relies on chemotherapy. It relies on pharmacy. And imagine the disruption that is likely to be seen from COVID from this last year. And imagine how we should be working across those different disciplines and professions to address this burden that is going to be hard to quantify. Next steps. Next slide, please. So what are ways that AAGS could address that need? How could we engage and encourage cross-disciplinary partnerships to address these needs? How could we engage in global health innovation, an area that's going to be funded heavily in the upcoming years because the need is obvious? How can AAGS partner with groups like COVID Surge to validate the results and then develop interventions, as Dr. Krishnaswamy mentioned? And how can we share and distribute resources on new courses like the surgical ecosystem course that Dr. DeVries is launching here in Utah next year? Next slide. Next slide. Lastly, there are numerous upcoming opportunities that we need to keep our eyes on. A key thing that is occurring now is that there's been a heavy amount of lobbying and advocacy by Dr. Price, Dr. Amira, and a whole bunch of other folks who are probably on this call right now. And for the first time ever, USAID has received a directive from Congress to allocate federal funds to support access to surgical care worldwide. And the number that's being discussed is $100 million. As that advocacy starts to bear fruit, we as an organization, our partners, our colleagues, need to be thinking about what we can do together to address the surgical care of our patients. Next slide. And with that, I'll conclude. Thank you so much for the opportunity to represent the University of Utah Center for Global Surgery, our founding director, Dr. DeVries, and our vice chair of global health, Dr. Price, and our team here in giving this keynote. I'll turn it back over to Dr. Krishnaswamy.
All right, thank you so much, Dr. Jayaraman, for your talk and your keynote address for us. It gives us a lot to think about as we go forward. I really want to remind everyone to please stay for the breakout sessions, which will follow the committee reports. They're going to be really key in setting up the general direction of the AAGS. This is a chance for the voice of all our members to be heard, and these breakout rooms will help inform the strategic plan that will be created for the organization in the next few months. For our committee reports and kind of going to the business of the meeting, I'd like to introduce Dr. Kristen Long, who's our newly elected recorder. Dr. Long is an assistant professor of surgery at the University of Wisconsin and a practicing endocrine surgeon. Dr. Long has worked on the ground in Kenya and Ethiopia and Palestine, improving access to surgical care and education over the last decade. She's a fellow of the College of Surgeons of Eastern, Central, and Southern Africa, and serves as a COSEXA board examiner and chairs the Global Affairs Committee of the American Association of Endocrine Surgeons. So, Dr. Long, please let us know the work of the committees.
Well, thank you so much. It's really my pleasure to talk with you all tonight and highlight the tremendous work that our multiple committees have accomplished over the last year or so. And I just want to start by thanking everyone that's been involved with all of the committees. We recognize this has been an extraordinarily challenging year, and the amount of work that's been accomplished is really amazing. As you can see here on the slide, these are our committees. As Dr. Krishnaswamy noted earlier, several of these are new committees, and so there may not be much to report. In particular, our Diversity, Equity, Inclusion Committee and our Emeritus Committee have yet to have a meeting, but we look forward to what they're going to accomplish over the course of the next year. The first committee that I'm going to talk about is the Accreditation Committee. This committee has done a tremendous amount of work over the last year. Thus far, they have developed a working document of guidelines for accreditation standards. They've been working to create a list of organizations that can help provide guidance and also allow us to partner with them, creating tremendous opportunities for people. They've collected examples of existing accreditation schema and appointed liaisons to several other committees. One thing you'll notice as we go through all of these reports is that our committees are incredibly proactive and cross-collaborative, hoping to end some of the silos that we see across the world of academic global surgery. So this really is a partnership of multiple people working together. They've also created a list of benefits, and harms to accreditation for programs, and moving forward to their goals for the next several years. They've done a really beautiful job of delineating what a 1, 2, and 3-year goals would look like. Primarily in the first year, they're hoping to deliver us an outline of accreditation standards and an application that we can then use to determine what the accreditation process for a global surgery program would actually look like. And outline how programs would go about doing that. They'll continually revise and address those standards, the application and the process, and hopefully over the course of the next several years, begin reviewing and approving programs for accreditation and continue to revise that and publish scholarly documents summarizing what they've worked on for the next several years. So we're incredibly grateful for them and their ongoing work. The next committee is our Advocacy Committee. They have met, they had their first meeting this month, and we look forward to them providing us with an annual work plan within the framework of what their goal is. They are hopefully going to provide us information on really important advocacy issues, as have already been highlighted in this meeting, for global surgery. So they will certainly be an important part moving forward. Our next committee is the Affiliate Committee. This group is working so far to identify relevant affiliate groups with whom we can partner. We want to be as inclusive of an organization as possible. They're going to be compiling a list of ongoing projects by the various AAGS committees and try to increase collaboration as much as we possibly can. They have a draft recruitment email to be distributed to all of our affiliate groups, and they're working to request biographies of our existing members that we can include on the website, and hopefully work to continue to expand our reach there. Their current projects, as we mentioned, are adjusting the website to represent the affiliates. Next slide, please. They're going to be contacting other national organizations and determining how we can best collaborate with them, including international organizations. Our goal is to have as many international members across the globe as we can. And they're working to help us partner with the G4 Alliance, the Royal College of Surgeons, et cetera, and finding as many places as we can that we can include in our work. Our next committee is the Associate Committee. This is a newly formed committee in the last several months. They had their first meeting in October. Their primary goal here is to support trainee interests. This includes mentoring, grants, research fellowships, job opportunities, dedicated time for webinars and speaking engagements. Like the Affiliate Committee, they are also going to be working to identify like-minded organizations that we can partner with. They've done a nice job of working to assign one point person to each item and try to collate some of our existing resources. And also hopefully working to identify some job resources. One of the things we would love to see both our associate and our education committee work forward is job search resources. How do you negotiate global health into your contract, building on some of the information that Dr. Jayaraman just mentioned? How do you, in whatever environment you're in, how do you make this a compensated and validated part of your practice and your work, because it's incredibly important and it deserves that recognition. So we're grateful for the associate committee moving that forward. Next, we have our Congress Committee. This functions effectively as our program committee, and they are working really hard to establish a standalone AAGS biennial assembly. Our goal is that in the spring of 22, we'll have a spring assembly, which will have a virtual interactive format. Education will be the primary focus. We're going to have speakers and breakout sessions. And then in the fall of 22, we'll have our fall assembly, which will be more research focused, including poster presentations and opportunities to submit your work. They're also, through that, going to hopefully be growing our student, resident, and international membership. The Education Committee has been working in several subcommittees to draft curricular resources that, as was mentioned in our prior talks, could be available on the website. We'd like to identify both basic and advanced curricula that can be presented. We think that there's obviously a role for every resident, every trainee to have some exposure to global health and global surgery, but we also want to provide practical resources that we'll be working in conjunction with the Program Directors Committee to provide for people who are facing imminent, international experiences and maybe traveling one way or the other. The Ethics Committee has presented us with a ton of information about some topics that they'd like to do deep dives into. This is obviously an area that we want to explore and try to provide great resources for our members on. Things like authorship, which is critically important in global surgery research, errors, trainee preparedness, conflicts of interest. Our committee in ethics is going to be working on that, and they've worked to establish liaisons to all of the other committees as well, with really the overarching theme of our committees, which is bidirectional communication, bidirectional engagement, and really trying to make sure we're engaging all the stakeholders that need to be represented in all of our work. The Finance Committee is, of course, going to provide financial oversight for the activities of the AAGS. This includes our esteemed treasurer, Dr. Dodgen, and working on the annual work plan. We will, as a newly formed organization, obviously are in the process of developing our operational budget, a long-term sustainable financial strategy that allows us to grow as an organization. We'll have policies for capital purchases and donations, and hopefully try to explore funding opportunities for global and collaborative activities, all of which cost money. The Governance Committee essentially has come from the initial charter of the Rules and Regulations Committee. They've worked tirelessly to help develop the Constitution that we ratified in the summer of 2021 and have helped us file for our 501c3 nonprofit status. Their ongoing goals are to continue partnering with us to develop standard operating procedures. They'll be working closely with the Ethics and the DEI Committee on this, and several are already under development. This includes things like sponsorship types and levels, committee member roles and responsibilities, general member roles and responsibilities, and what our dues structure and evaluation cycles will look like. The IT Committee is as it sounds. Our goal with this committee is that they're going to continue their work of renewing the website with updated events, keeping things accurate, demonstrating our core values on the website, building a map that shows where people are working, where collaborations are, and then, as is imperative in our world today, building upon social media opportunities. So we do have a Twitter account, we have an Instagram account. We hope you'll follow us there. And the IT Committee will hopefully be providing incredible content that you guys can share and share your accomplishments through that as well. The Membership Committee has worked really hard to establish both a dues structure and decide what our membership form actually looks like. We want to make sure that we have opportunities for everyone to join. That includes the multiple types of memberships that you see here. So active, affiliate, associate, emeritus, and student. But that also includes having a tiered structure for the dues that we will eventually be collecting as an organization. We obviously need that to move forward, but we've tried to stratify that and make it as equitable as possible for people across the globe to join us. Their goals for the upcoming year are to continue to evaluate our intake forms and make sure that we're capturing information that will allow us to really assess our membership and identify areas where we could recruit better. They're going to be working on regional focuses of our different members and how to unify people across the globe. They'd like to collect areas of expertise of different members based on publications that can then allow us to provide mentorship opportunities and again, cross-collaborate across the committees. So that's our common theme that you'll see throughout all of these. The Nominating Committee importantly met and agreed upon the slate of nominees for the executive leadership that you're meeting tonight, and is continuing to work on standard operating protocols for future executive elections and how the leadership of the organization can continue to serve you all as the membership at large. Our program administrators have accomplished bi-weekly meetings to try to discuss goals and projects of the committee, working fairly closely with the Education Committee. They're creating a toolbox for programs. So our long-term goal for this group would be that we have a toolbox for programs that are accredited by the Accreditation Committee and allow them to build and elaborate on the global surgery programs that they're trying to create. This hopefully would then be shared with programs across the globe and be an accessible resource for everyone. Next, we have our Research and Quality Committee. Similar to the Education Committee, this has been divided into several subcommittees. Their goal is to facilitate research and quality projects in surgery really around the world. They have a committee working on a research and quality survey, which is hopefully going to determine the needs of the organization and focus their efforts. They're looking at stakeholders and environmental scan, trying to better our overall organization to engage as many stakeholders as we possibly can. And they're building upon a list of resources related to surgical research and quality. For the upcoming year, they have several goals they've presented to us. This includes further refining the strategic plan and focus of their committee, trying to publish, disseminate, and update resources for global surgery, looking to collaborate with the ethics committee regarding research ethics in global surgery, which we've heard as a topic mentioned several times tonight. They'd like to map the research and focuses of the AAGS membership and develop a repository of people who are interested and looking for assistance, which I think is a key way we can connect each other within the organization. Our student committee has held their first meeting. They talked about their goals for the committee and have scheduled meetings planned. I think their primary goal, as you'll see in the next click, is that the ensuring critically important student views and insight is shared with the AAGS committees as a whole, and work to continue including and developing diversity, equity, inclusion, sustainability, education, and support of the students. And as is every organization's goal, hopefully connect students with mentors and opportunities to nurture skill development. These are our incoming leaders in global surgery, and we want to make sure they are very well represented within this organization. Finally, we have the Institutional Representative Council. As you've heard, they have had their first meeting with institutional representatives. 15 different institutions were able to attend that first meeting. Basically, that was to discuss the role of this Institutional Representative Council. They addressed concerns of institutions with question to collaboration. And their goals for the upcoming year are to share the contacts of all the institutional representatives, serving hopefully as a first point for collaboration. They'd like to develop a podcast for global surgery, collaborating with the well-known podcast Behind the Knife. They're going to be working with the Education Committee and the Advocacy Committee to hopefully develop some position papers. Again, highlighting our intent to develop best practices for a lot of the work that we're doing. And they'll be addressing all of the institutional concerns for projects moving forward. And I think that is the last of our mini committees. So I just want to, again, take a moment to say how much we appreciate all of the work. Please reach out to any of the committee leaders or to any of the leadership if you have questions about our specific committee work, and we'd be happy to share more. Thank you.
Great, thank you so much. I want to also echo thanking all the committee leaders. They've done an incredible job, and the committee members have just put in yeoman's work to get all this stuff done in just a year's time. The leadership of the committee also, besides being on these slides, were are listed on the website, so feel free to reach out to any of them individually. Also, feel free to reach out if you have any comments or questions on any of this. Feel free to throw it in the chat as we go along, and then we'll have a little time subsequently to kind of interact in small groups, as I said. The next thing that's up is the Treasurer's Report. I'd really like to introduce Chris Dodgen, who's our newly elected treasurer, was a member of the advisory board and is one of the founding members of the organization. Dr. Dodgen is an associate professor of trauma and acute care surgery and the director of global surgery at the Medical College of Wisconsin. He is past chair of the Global Affairs Committee for the Association for Academic Surgery and is the current AAS representative to the G4 Alliance. He's the co-lead of the trauma subcommittee of the American College of Surgeons Operation Giving Back COSEXA collaboration with Hawassa University in Ethiopia. His AGS work has focused primarily on strengthening trauma systems and expanding quality improvement initiatives in low resource settings. So Dr. Dodgen, if you can give us our Treasury Report.
Wonderful. Thank you again for the opportunity to serve. I really appreciate it. So as you can see here, for the last year, after the formal launch of AAGS, just over a year ago, the time goes quickly, membership has been free for the first 2 years. As AAGS becomes more established, develops its initiatives, and expands its membership, dues will remain as you see here. Those of you who are current members will be receiving invoices shortly for your annual membership dues. We hope that you remain members and refer others for membership. Only together can we work to achieve our goals, as I mentioned earlier, of ensuring safe, effective, timely, and affordable surgical healthcare for all. Currently, we've collected just over 8,000 in dues, donations, and organizational sponsorship. Primarily, this has been from the advisory board members, as well as members of the leadership council, or the heads of the committee. Again, general dues invoices will be coming out to your email addresses for those registered members within the next month or so. So please look out for that. Overall, our operational expenses total to date for the last year about just over $4,000. That includes the cost for our initial nonprofit incorporation status, or filing, maintenance of the website, and domain, subscription to online service to help us with organizational membership management, dues collection, and basic kind of email software, and then cost for some Google and Zoom accounts and QuickBooks to kind of keep track of all of our finances. Thank you again for the opportunity to present. Please let me know if you have any further questions.
Fantastic. Thank you so much, Chris. We are now going to break up into pre-assigned breakout rooms. You will remain in your rooms for a period of 20 minutes, where you'll discuss with a moderator 2 questions for 10 minutes each. The session will be video recorded, and there will be a scribe in each room. These questions will inform our strategic planning meeting to be held in the next few months, so please do participate and engage in the conversation. At the end of the 20 minutes, we'll all return to the main room, and each group's moderator will have an opportunity to summarize each question's responses. The executive leadership will review all the information from each breakout room in the coming weeks. You'll be now split into the breakout rooms.
Hi everyone, I'm Savannah Geisling. I'm a doctor, an academic foundation doctor in the United Kingdom, and I'll be moderating the session today. So welcome to you all and welcome to this breakout session. I'm also the Vice Chair of the Congress Committee. So today we'll be discussing quite a few questions, and the aim of this is that the discussion will inform the direction of the AAGS and further strategic planning. So it's really a chance for you to get involved, to
Hello, everyone. My name is Katayun Madani. I am the Executive Secretary to the leadership of AAGS. Welcome to the breakout room. I am, sorry, getting a message regarding recording. So I apologize for 1 second. It seems like there's an issue with recording in the rooms. So we're going to discuss topics that are going to be used for the strategic planning of the AAGS. So I'm going to actually respond to our scribes quickly, and then we can get started. Okay. Alrighty. So what we're going to do is look at 2 questions in terms of the strategic planning. I'm going to bring those 2 questions up for you momentarily. Would you like to do a round of introductions just so that everyone gets to know each other? How about we do that first? I introduced myself, so please open your mic and just introduce yourself. It's not a very formal meeting. We want to get to know each other and talk about AAGS. So,
my name is Nicole Rykar. I am a trauma and acute care surgeon at Brigham and Women's Hospital in Boston, and that's it.
Very nice to meet you, Dr. Rykar.
You're still on mute, Dr. Seaton.
Yeah, I believe so.
Is it working now? All right, Jillian Seaton, general surgeon, was in Liberia for a number of years, and then Malawi, just returned to the US.
Welcome. It's very nice to meet you. And I think
Nice to meet you.
we have Philip joining us too. Philip, would you like to introduce yourself?
Absolutely. Sorry about that earlier. It seems like my audio had some bugs, but I'm Phil. I am an intern in general surgery at the University of Michigan.
Welcome. So let's see. So just to get started. So first question that we want to chat about is, what should AAGS organizationally focus on in the next 1, 3, and 5 years? And, you know, you had an overview from the chair about what has been going on, from the president, and also the committees and what they have been doing. In your thoughts, looking at the presentation also by Dr. Jaraman about the priorities in academic program development overall, how would you think we should proceed in the next 1, 3, and 5 years? Any thoughts are welcome.
I think I'm still a little bit unclear on exactly what of the numerous significant questions or issues, challenges AAGS wants to tackle, because there's a lot of obstacles to proper surgical care. And we're talking millions of dollars and tons of hours of work. What is it that AAGS wants to do with what people are already working on already? Are they trying to consolidate everybody's work, be a central conduit for everybody's work to go through? Or is it that they want to, I guess I'm a little unclear. It seems like an awful lot to try to grapple with. And it seems like being a little bit more practical, maybe, especially on the first levels of steps, would be a little bit more successful and would help kind of consolidate all the efforts that have been going in. So does AGS not have a particular area that they want to try to tackle? Education or systems in Africa or systems in Asia? I mean, like, those are extremely different, although probably the challenges are very similar. The solutions are probably going to be different.
Exactly. So I want to ask everyone else what they think AAGS is focusing on right now. What did it appear to you? Because obviously, from my point of view and our meetings, I have a viewpoint, but I'm really, this is a very interesting point that you raised, Dr. Sitan. So I want to know if others have the same question about AAGS, or do they think that they see a clear vision here? Because that would be very key in us determining our strategic plan. If our vision is not clear to our members, then we need to really narrow the focus. I agree with you.
Well, I think that, you know, it's very challenging I agree with Dr. Seaton. There's a tremendous amount of variability in where this organization can go. There's 101 different ways that we can define academic global surgery and then proceed along with it. Dr. Krishnaswamy presented one definition of academic global surgery, which is pretty good, but certainly I think there are challenges in the months and years ahead. I think the big challenge area of concern for me is that there's this growing divide between how we view academic global surgery in my context, I would say high income country context, but really I mean the United States. It's very much a lot of the things that Dr. Jayaraman sort of presented during her excellent talk earlier today, but there's a divide between people who are who consider themselves a part of the academic global surgery community and doing academic global surgery versus people who are actually practicing surgical care delivery and providing care to the world's most vulnerable populations. And so you have that entire subset of people, I think, who don't necessarily identify with being global surgeons, even though they are very much the bread and butter of what I think what a lot of this work aims to do ultimately. So that would be a huge hope that that this group really tries to actively bridge that divide over the course of the next year, and at least explore what that divide means. I think that the surgeon in Bihar or Liberia or wherever they may not necessarily perceive their work as that of global surgery, and I think we need to address that early.
I think you really hit it on the head. I mean, I'm coming in being trained in a high income country, but having worked in very low income countries. And so I'm very much from that other side, non-academic, non-connected kind of settings. And the discussion is interesting, but I see a huge gap between the two, where yes, the discussion is being had that they've identified the challenges, yes, and we keep redefining them, which is probably helpful on a global or a national scale to say, hey, ministries of health, you really have to invest in your surgical services because hospitals have no resources whatsoever to do it. There's quite a lot of disregard for surgical services as it is, between administrations, between politicians, and all that needs to happen probably on a large scale. But none of that actually directly translates to surgical care. And surgical care really, in those kind of settings, really comes down to individuals who are on the ground, who pull in resources if they're able, or just put a Band-Aid on it. Or duct tape or whatever you actually have. So and seeing all the obstacles for even people who do try, getting shut down over and over because there's things well outside of the control. So these discussions are very interesting, and it's really great to see so many people interested in it. But how would you break down these challenges that we've been identified? And where would AAGS fit in with all the other organizations that are doing this same sort of work, but not necessarily under the auspices of a global organization? And is that AAGS's goal, is to unify or provide a central command, so to speak, for all these organizations? And if so, that sounds great. I guess my big question is, does everybody have that kind of buy-in?
Great points all around. I have some comments, but I want to hear from Philip.
Yeah, thank you so much. And I really appreciate all these points that the two of you, Dr. Steven and Dr. Baker, have been making. I come from a place of, I guess, humility and a lot of privilege in that, as an intern who is very new to this field of global surgery, I feel sort of like an outsider looking in, and hearing about all this conversation, it's given me a lot of ideas, but whether these ideas can be put into practice, that's something that I'm still trying to figure out. And so I agree with a lot of the things said, especially Dr. Rekar, what you mentioned about bridging this disconnect between the people who are already doing the work and the people who are working at this very high level in a high income country, sort of as you alluded to, Dr. Seaton. And I think it makes me think of three specific things that could be a focus. The first is, it seems like AAGS right now is spending a lot of the effort trying to define what our goals are and trying to define, okay, what has the literature said about this? What are the steps that we need to take? And I think that is something that is very important, but also it's something that that would be really useful if we could expedite. And so we could get on to the second step, which is making that big difference in LMICs. And I think what that would involve is especially having surgeons who are doing this work already in the LMICs be a part of these efforts directly in AAGS. I noticed that the majority of attendees here, not surprisingly because it's such a new institution, are people from the States. And if there could be more collaboration specifically set up between AAGS as an organization and these surgeons in LMICs, whether they are from the LMICs themselves or they are expats from the United States practicing there full time, I think could be really useful. And the third is talking about funding. It was super exciting to hear Dr. Jayaraman talk about how much funding that we're trying to get for global surgery. But I think one of the main issues, especially in LMICs, is the fact that we do have ways to fix these surgical problems here, and we can't translate them over. A lot of it's because of funding. And if there's a way that we can advocate and pour funds directly into efforts in LMICs, whether that is for quality improvement or even just to pay surgeons to be able to do the job. I know I'm sure that there are people in the States who are interested in global surgery, may not have either the experience or the interest in the capacity building side from the States, the whole public health, big data analysis, health outcomes, but would be thrilled to be working directly on the ground as surgeons. I don't know if that would be possible, but these are very lofty ideas that I would love to hear your thoughts on.
So I really appreciate all the points of view that you raised. And I think at this stage, yes, you're right that AAGS is trying to find its focus and trying to narrow it, because as you said, there's a lot to be done and it's very hard to narrow what we need to do. I think from our standpoint, majority of us at least see that AAGS has a niche compared to other organizations such as the G4 Alliance, the Global Surgery Foundation, and other organizations, in that because of the academic nature of and the academic positioning of its members, it has access to places to advocate for formation of these programs, unlike any other organization. Some of our most prestigious and powerful advocacy groups are able to, advocate at the level of UN, WHO, etc. USAID, right? We just heard about that. But to have the ear of program developers, the deans, the boards of regents, the university presidents, we do not have any other organization other than AAGS that has access to that at this point. And
so is it more of an upwards approach, like the AAGS takes the studies, the feedback from surgeons, the educational criteria, and then turns that over and upwards to get more policy change? Is that one of the main goals?
It can be, but more so to develop academic programs. At this point, if you look at, for example, I'm also chair of Incision, the International Student Surgical Network. We're only 5 years old, yet in 5 years, we have spread into over 52 countries now. So that shows you the interest that the students and trainees have in global surgery. There's papers published that show in US in particular, if applicants know that a program has global surgery components, they're 70% more likely to rank them higher. So there is a vast demand now for academic programs that train global surgeons, whether that is training in policy, training in advocacy, training in research techniques. And this is not just limited to high-income countries. In low-middle income countries, that education becomes very important. As Dr. Jayaraman was pointing out, there are not that many programs that are capable of delivering that right now globally. To develop those programs, yes, we need funding, but we also need the support of the universities, the academic side of things. And if we have that support, if we have the creation of these programs, ultimately global surgery will be seen as a fundamental field and a fundamental part of surgical care. And it will lead into jobs in global surgery. At this moment, we are having a session actually dedicated to students and trainees for American College of Surgeons. We do it every year. This is our 3rd year doing it. This year, the request was to have a breakout session dedicated to careers in global surgery. Students and residents want to know, if I want to become a global surgeon, is there a job for a global surgeon? And in the US right now, 1, maybe 2 postings of jobs exist for a global surgeon. In reality, there are 90 people on this call that all of them are global surgeons. So majority of them are actively global surgeons. Some of them are students and trainees. So how are we going to create these jobs? Because this program development and these job developments has to happen for the ecosystem to move forward, for infrastructures to be developed around the world. And you pointed out a really important point, I think, and that's a divide in the view of what is global surgery and academic global surgery and sustainable work in this area. And I think that's very important and very valuable for the organization to keep in mind. Does that help with a little bit more of how the AAGS is trying to navigate the system?
Somewhat, yeah.
So that's the ultimate goal. But as you said, there's so much more to do. I mean, all of these committees that we have, they're going to have to actually be able to contribute to that process.
One question, and I must have missed it. Maybe it wasn't explicitly said, but who is AAGS accrediting?
So the Accreditation Committee is making accreditation guidelines for when the programs are developed. Right now, there is no core competencies for global surgery courses. You know, if you're taking a biology course, whether in US, if you take it anywhere in US, no matter what the name of the biology, primary biology courses, 181, 182, whatever you want to call it, it's the same stuff. If you take it in another country, primary biology in college has the same content, anatomy has the same content. What is the core competencies that someone should be educated on if they're in global surgery? We don't know that.
It's like the global surgery training of various aspects that you want to accredit. It's not surgical residents per se. It's somebody who wants to emphasize or get extra training on that particular.
In that particular area, or if it's a residency program, what makes a residency program accredited in global surgery? ACGME has some criteria. Loma Linda had an exchange program that was ACGME approved. Baylor now has the global surgery residency that has one spot per year for a resident in the entire world. So, I mean, who is going to accredit these? Who is going to standardize these? And what is going to be the core competencies that anyone who wants to go into this field should know? Because right now, everything is very freeform, which is beautiful. But on the other hand, do we need standardization? And I guess that's the question. What are your thoughts on
Also, the question of, you talk about, are there jobs available?
Mm-hmm.
And I'm sure that especially as surgery and changing healthcare towards surgery across the world meets more like, if USAID is going to need surgeons or people in global surgery to help allocate $100 million and decide what programs are there. So I can see that there's some growth there, but just speaking back to that gap thing, I mean, there's people that do this already without training, and most of them are not in a high income country. So and most countries wouldn't be able to afford to send anybody to a program here in the US. So it seems to me that the AAGS should be looking towards how can we establish either online or outposts in other continents, at least, where people can attend these kind of classes, because I can guarantee you, Philip, for instance, if you wanted to take a year out and do global surgery in business administration or something like that, you would learn a whole lot more outside of the US than you would inside the US. Because although you could get very good education in the US, it's not actually applicable outside of the US in a lot of ways. And you wouldn't see the corruption and the other things that kind of bog down the systems in other countries. So it seems to me that accreditation would be highly useful if it was done through outside universities. That's not to say that we don't need them in the US, because we have a lot of interest, obviously. But I feel like, again, you're training somebody in a high income country for a high income job. There won't be that many of them.
No, the point is to actually create training programs globally, actually, exactly what you said, because that's where the area of need is. And in fact, this is where we can learn a lot from our LMIC partners. Now, the issue is, how do we engage them? How do we actually bring their voices in? Because programmatic developments are difficult in US, it's going to be more difficult even further in LMICs. How do we engage them in a meaningful way? How do we provide support for them to set up their own programs so that the students online is great, but maybe they can just learn in their own environment with their own faculty? Because at the end of the day, faculty in every country know the climate of surgical care in their country the best. So how do you think that we can actually do that? What is the best way to engage them?
Not having had academic connections in the countries I worked in, that's a little bit harder to answer to. just by seeing some of the things. I mean, COSEXA is a British-based training program, and so they're very, very protective of that system. So for instance, for surgical trainees in COSEXA programs, you have to get a master's in surgery, which includes a master's project and paper, not as much emphasis on clinical experience or surgical experience. So, you know, to entice or to interest people within that training program or those training rules, because COSEXA is British, and yes, that's a surgical organization, but that's also the schools based for the entire region of Africa. So you would want to be able to attract somebody who could get the credentials that are recognized in the British system as well. So you're talking a lot of complicated paperwork and getting people approvals, but I think that's a really great way to look. The thing is, some of those programs might be there already, right? So I think maybe that's where AAGS can really focus on this stuff, because they have the academic ties already to say, well, let's go outside and go to other governing boards and see if we can be partnership. That way students don't have to accredit two different systems. I mean, they don't have to meet criteria for two separate systems, but can go through one system and still be accredited through multiple organizations.
That's fascinating. I think that's really those types of connections and initiatives could make life easier for a lot of people. You know, I think one of the things that we should do as a group is, you know, it's easier and easier now to get in touch with folks all over the world. I think the students and Incision actually are pioneers in this, right? Like you guys are all over the place and have, you know, whenever there's a survey or a project that involves that requires sort of a broad range of individual responses, the student groups are very effective at reaching a broad range of individuals. Now, I think that a lot of those individuals who respond to those types of things are still very academic, even within, you know, just more globally than traditional channels. So I think if we can, there are WhatsApp groups, we just need to find them and get into professional societies within different countries and regions, and then offer something that these individuals would want, whether that's professional development support, whether that's, you know, a vacation, right? Or some sort of exchange program, right?
Conference attendance.
Yeah, exactly. Those types of things I think could potentially be useful.
There's a lot of interest in that, by the way. I think that's a great incentive to offer.
Very, very interesting point. We have 26 seconds. Any final thoughts?
It's great meeting everybody.
Yeah, thank you.
Thank you. Thank you for bearing with me as I was navigating, chatting, and working with our scribes. But I think these are very helpful, and I'm sure the executive leadership will really find them helpful in finding them.
As said by President Dr. Krishnaswamy during his speech, to support the hospitals or the institutions in low middle income countries in terms of the development of infrastructure or equipments. Why I'm asking this is, at the moment, the hospital I'm working here in Nepal is starting a new surgical center, a different one. And then so you need a lot of assistance at the moment. Would be of great help in terms of infrastructure or any sort of technological or expertise. So that's why I'm asking.
Yeah, I think that's a great question. I don't know that we have a great answer right now, but we will discuss it amongst the leadership, and we will keep you posted for sure. Thank you for raising that point.
Thank you, Dr. Long.
Well, you guys, we are back from breakouts, and just to give you one additional chance to complete this, if you didn't have an opportunity to complete this, if you could please let us know If you came late or haven't done it, if you came in late, please do this now. Please go to the bit.ly that will be put into the chat for you, and let us know why you came to this AAGS meeting today. Why are you present here with us today? Dr. Madani, if you could add into the chat, or Upasana, if you could add into the chat the bit.ly link, that would be fantastic. And just let us know in 3 to 5 words what brought you here today. That would be great. And I promise it will be worth it. I promise it'll be worth it. You will be very happy with the reason why I keep pestering you with this question. I'm going to turn it over to Dr. Nunez and Dr.
So go ahead and advance the next slide.
For the breakout room discussions.
Great. Thank you all for participating in the breakout discussions. Hopefully you had an opportunity to give your input again to shape the future of our organization. Now, as mentioned by Dr. Swaroop, we'll have Drs. Jade Nunez and Savannah Geisling, Chair and Vice Chair of our Congress Committee, lead the summary feedback from our breakout sessions. So just to give you a flavor of what was discussed, again, we did record all the breakout rooms, and we'll be going through that at our future strategic planning meeting within the next month to be able to create our goals for the next 1-, 3-, and 5-year plan, which we'll share with the rest of the membership shortly thereafter. So Dr. Nunez, go ahead.
Great, yeah, thanks for having me. I'll probably the best way to go about this is to defer to each of the moderators for highlights from their breakout rooms. I'll start with mine. We had a great discussion coming out of question 1. What should we focus on as an organization in the next 1, 3 to 5 years? I loved it that the rooms were broken up, at least ours was, into student, resident, and attendings. We had good representation. The things that came up were to concentrate on increasing the awareness of global surgery to students. I think as you're coming in as a student, you don't really know what's out there, and because global surgery is fairly new, especially in the realm of public health, and that awareness is being increased. One idea was actually to talk to the AAMC or other bodies making curriculums to highlight surgery in public health. Another point was to act as an organization to increase awareness within high-income country actors to our sort of our guide our ethics around our practices, as well as to really make us aware of how our worldview affects what we do, so that we can really speed up that learning curve to be responsible actors on the world stage. And then question number 2, we talked about really acting as an umbrella organization of global surgery to really connect people, to not only connect practitioners from high-income countries to low and middle-income countries, but to connect low and LMIC to LMIC, to act as a central hub, allowing for relationship building. Another point was brought up to really help raise awareness of what global surgery is to professional bodies in LMICs and middle-income countries by reaching out to their professional organizations. And so I'll turn it over to Savannah. I've been alerted that we should limit each summary to 1 minute, so my apologies.
Hi, I'm Savannah Geisling, an academic foundation doctor in the UK and vice chair of the Congress Committee. Again, we had some very interesting discussions in our breakout room as well. In terms of the first question, one of the main points was looking into the actual needs of low and middle income countries and creating a bit of research and work on that focus, first of all, because a lot of times, like we discussed in some of our introductory talks, we can have a bit of a high income gaze on things and not actually be completely aware and acknowledge the actual issues and problems that are being faced in low and middle income countries. And that's an area of work that really needs to be hashed out, especially if we're trying to focus on interventions and programs and that aspect as well. So that was quite an interesting point we looked at in that regard. In terms of the second question as well, we discussed making a platform in terms of making the academic aspect of AAGS quite a big of a focus, because there are quite a few other organisations out there and programs out there that focus on global surgery, but that the academic side is not always necessarily quite as pronounced as it could be. And that being really part of the platform, and when we focus on the role of universities and academic institutions, when we look at establishing programs and interventions and collaborations with low and middle income countries. So there's quite a few interesting points there overall as well.
Okay, maybe I'll go next, Jade. So our group kind of talked as far as the 1, 3, 5-year goals. We talked about making sure that we appropriately emphasize and kind of organize our organizational membership due structure. Everyone acknowledges no easy way to do that. Another thought was that marketing of the organization, perhaps through a periodic newsletter, among other things, but somehow figuring out how we can market the organization is critical. And then one other thing was really serving as a repository and centralized body for all global surgery programs in terms of residency programs, so they can speak with one voice, and so one resident can go to a place that is a repository of information for that. And then the last thing on that was being a force multiplier in research, where we could ultimately serve as a research consortium across centers in multiple continents. As far as the second question and what our role is internationally, perhaps improving communication to connect surgical societies across the world was brought up, and kind of making sure we create documents that and kind of framework for setting expectations for LMIC partners and HIC partners in terms of how we interact around a partnership, and even help them inform what their expectations of us should be, and vice versa. So that's what we discussed in our group. See who's next.
I can go. This is Ray Price. For the first question, I think they dovetailed into both the first question and the second question. We really only got to the first year. We couldn't get to year 3 and 5, didn't have enough time. But they really dovetailed in really introducing AAGS worldwide to academic institutions around the world, and specifically contacting many directly to invite them to participate, to share with them what AAGS is. It was suggested that AAGS vision, mission, and objectives is very similar to some of the surgical societies' mission and visions, such as the Filipino College of Surgeons and other groups around the world that might be something that people would be very interested in. And what our role would be, dovetailed into that, as being able to really reach out to these organizations and to bring them in under a roof under the same vision and mission, but into doing some specific things that could be a library of information from around the world, places that are doing global surgery, specifically for students and residents, for opportunities for trainees as a database. But then there are some comments about potentially being able to do global research together, choosing one topic that maybe all groups that are working on this together could have a greater impact. And then a real comment on, can we come up with some ways that we can come up with some standards in quality, both in the global surgery work and research in many areas. I think one of the comments that was really interesting is it may not be the same for all the different committees. They may be different goals for each of those that would need to be done. That's what we report on.
I can go next. I'm Marianne Hopkins, and we had also an exceptional group, I will say. And we thought the focus in the first 1 to 5 years should really be on increasing international representation and membership, specifically students and registrars or residents at that level, since they'll end up being sort of the future of the organization. And we thought some ways of doing that would be to look at, say, the alums of the American College of Surgeons travel program, or for us to reach out to people that we individually know throughout the world that might be able to become members and then future leadership. We thought, again, like many, that we really need to emphasize our difference from other organizations that do similar things like the military, US government, religious organizations, and NGOs by emphasizing and defining what is academic. Is that research, quality, educational materials, or both? And we thought we should spend a fair amount of time on developing bi-directional educational tools and or resources, so that should be a primary goal. We also thought that perhaps the timings of the meetings should be better or at least maybe changed around so that people could participate. In terms of the second set of questions, the repeat thing was really developing true partnerships with low-income countries, and this will make us sort of different. We'll emphasize our education, our research savvy and research programs, maybe even developing research mentoring programs for low-income countries, but to also show a dedication to changing policy. We thought this, instead of just publishing a paper and saying, hey, look, we can do laparoscopic surgery here, but working to develop changes in low-income countries, in middle-income countries, in our own, to really emphasize global surgery, and not just the research that maybe it sort of leads nowhere. And we also thought that we should really, and this was very strongly felt, that sort of almost developing a universal educational curriculum that was accessible worldwide, so that surgeons everywhere can have equal training, whether that's through development of a curriculum, of resources, of exchange programs, et cetera. And really emphasizing, we were struck by our keynote speaker on her acknowledgement that open access really doesn't exist in the research that's being done, that only 20% of the papers are there. So we ended with a question: should we be facilitators or doers, or both? So I'll leave it with that.
Wonderful, thank you. How about Dr. Lamati? Juliet?
Yes, I am here. Hi, everyone. I'm Juliet Lamati. I'm one of the I'm a surgeon fellow here at Hopkins. I was not leading the breakout room session, but I just had some kind of comments regarding this idea of global engagement and really creating opportunities to build and establish relationships between high income and low income countries. And I myself, being a diaspora and African, I find that there are definitely very different perspectives when you go to, for example, the Ghanaian Medical Association of America's conference, or the Association of Nigerian Physicians in America's conference. And I think that, traditionally, a lot of these diaspora organizations haven't universally been engaged in the same way as engaging COSEXA or WASC or some of the regional accrediting organizations across sub-Saharan Africa. And so I think, what I would like to see is an opportunity to engage those organizations, because 9 out of 10 times in many of our big academic centers with established global surgery networks, you may have, a couple of faculty, residents, fellows, students that are actually from these countries. But yet, when you look at our, conference attendance and who's actually speaking and who's getting engaged in doing the work, that may, kind of be a little bit different. So I would love for opportunities where, I go to AMPA and I come to AAGS and it's the same people and they feel like they have a voice, because I really do feel like the diaspora is really the missing voice of global health as it speaks.
Thank you. Jonathan Nelamo, did you lead a breakout group?
No, I think
I can go.
Yeah, I can go. I led a breakout group. And that actually, what Dr. Lamati said, segued perfectly into what our group discussed, really with an emphasis on expanding the bidirectionality and serving as a model organization of how do we really, not only how do we engage our members from low and middle income countries, we want to make sure we have an equitable recruitment process into the organization, but we want to really lay the groundwork for how we bring visitors here and allow them to join us in the operating room and make things more than just an observership. We want to advocate for equity in terms of connectivity. That was something that was brought up, I think, in the chat right as we were coming back into the main room as well. And we want to push for, as was also discussed, having a lot of educational resources available asynchronously on our website, potentially to our partners across the globe that aren't, egregiously expensive or single-use, single-time educational opportunities, because we really think that we could be a model for how we do that and share things across the globe. So those were our two primary points in my group.
Thank you, Dr. Long. Dr. Zalamea?
Yes, thanks so much. We had a wonderful group as well, and just participation from everyone. And our area of focus primarily was to be unapologetically academic, and that being the distinguishing factor that really makes this organization different. It's a challenge and also an opportunity. And so to focus on that, and perhaps even, as we looked at the mission and vision, understanding that as we do increase our international representation with the hopes of perhaps being 50-50, that some of these, just like the Constitution, these are all living documents, that there may be a need to modify and addend or change some of the wordings and the language that we use in order to really demonstrate that academic focus, as academia has an opportunity to offer and be a different type of voice within that global community that question number 2 refers to.
Perhaps I'll go next. So we had a really great discussion, echoing some of the comments I think made by others before. In particular, Dr. Hopkins' group felt like for the first question in terms of 1, 3, and 5-year goals, that really education should be the focus, both as Dr. Jayaraman talked about, sort of curriculum development and education, but also developing resources and potentially sharing those with ourselves and not reinventing the wheel, but also with low and middle income country partners, again, to ensure adequate access to resources, whether it's articles, different skill development courses, etc. Research courses was another theme. In particular for the second question in terms of how best to engage with the global community. There's lots of discussion regarding the importance of championing LMIC partners and assisting with research activities to, again, help have data that can be published locally, support local journals, and really better develop the expertise within the global community and partner together.
Great, thank you. How about Dr. Madani?
Thank you so much. Our discussion was also very engaging. I think the beginning of our conversation was from looking at the mission and vision of AAGS and discussing how in grand scheme of things, there is a divide between what the high-income countries versus low-middle-income countries and low-income countries may consider global surgery work and academic global surgery. And perhaps that is something to revisit and focus on as we are in the first year of our work with AAGS. In the long term, the conversation within the group was that we need to really engage the voices of our partners across the globe and make sure that the programmatic development is done in such a way that it provides opportunities, especially for the LMIC partners, whether it is through programs in their countries or programs that are accessible by individuals in those countries who are interested in taking advantage of these programs. We discussed the role of AAGS, and especially developing such programs. And in terms of how to engage our partners, the conversation led to professional societies that exist. Perhaps that would be one of the first places to get into and try and make connections. The other recommendations included tapping into the networks of individual members, asking them to invite their partners from across the globe to AAGS, and also taking advantage of our connection to students and trainees through organizations such as Incision to bring on faculty and partners from around the world, and also create more access for students and trainees in LMICs and across the world to programs that are developed through AAGS. Thank you so much.
Thank you. Dr. Swoop, I think you're our last one.
I am. So we had a great conversation, a nice intimate conversation, and we focused on our first question on quality and also on emphasizing equitable bidirectionality. And that should be our focus as we bring everyone together. And it came up as we were discussing our second question that we should be focusing on our low middle income country partners and developing our membership in that regard. And as we started to discuss, question 2 and also in the end of question 1, we also, wanted to annually be able to realize and discuss whether or not we were hitting our mission and our vision on an annual basis. And as organizations increase in size, the discussion focused on whether or not, our organization would remain focused on our mission and our vision. So I think that was very important. And, on the second question on how we should engage globally, I think, the biggest thing is what is the benefit of being a part of AAGS? And that's, something that all of us, need to discuss and, make a point of reaching out to our collaborators and, really, putting our, as we could say, is putting our work into it, right? And, making the organization as achieving as it should be, and making it as wonderful as we all think it should be. And so I think that, that's kind of where we are. And then as we get bigger, making sure that we have full transparency of what our high income country partners are and what our low income country partners are. And through that transparency, being able to know that there is a constant effort that we are trying to be equitable and to have that transparency. Thank you so much.
Okay. Well, thanks everyone. That was a great discussion on the critical things that are really going to help inform our pathway going forward. Towards that end, these are the immediate next steps for the organization. We're going to have a formal organizational strategic meeting, which we alluded to, which will occur in the next 2 months, and an election subsequently for additional members to populate some of those newer committees, as well as some of the older committees that have a relative dearth of members. So please keep an eye on your email for that, and keep spreading the word about the organization. The spring assembly will be in February, March timeframe of next year, and it will be virtual. In the fall of next year, we hope to maybe return to some measure of an in-person meeting. We'll all have to figure out what that means and how we continue to include, representation from around the world. In the interim, we'll continue to have regular committee meetings amongst those members here that are on committees, and we'll be in touch with all of you via email on a regular basis. We have about 10 minutes left, and I want to open up for any questions that any members have about anything we talked about. So I'll leave it at that. Any questions? Is there, okay, Jonathan Nellermo, you have something to, you have your hand up. Maybe that's old. Any Joshi, do you have any questions? I see your hand is up as well.
Yes, Dr. Krishnaswamy, as per your talk today, so I had asked this question before as well, like what would be the modality that you have envisioned to do skills transfer or any sort of equipments, technology transfer to institutions in LMIC?
I think you're asking, do we have any particular vision for some kind of technology utilization and instruction for LMIC members or institutions? Is that right?
Yes, like as you said during your talk today, like AAGS plans to support institutions in LMIC in terms of like sort of instruments, equipments in infrastructure development. Why I'm asking this is the institution I'm working right now in Nepal is starting a new surgical center. So it would be of great help if a center, a well-established center in the high-income country would help build that institution, because we are starting from the scratch at the moment. So so it would be great help for us if we could get any sort of support at an institutional level to make the surgical care, education, research, training, and improve the quality of these things.
Yeah, I think what you're, as far as kind of human resources and intellectual resources, the organization does abound in that, and this is something that we want to do to promote twinning, to promote institutional work across geographic borders. Will we be directly supporting as an organization a specific center in terms of material stuff? Well, you saw the budget, we obviously can't do that, but we certainly can hook places up, such as your institution in Nepal, with other institutions here, that potentially could do that. So I guess more to come on that. Any other reactions to that? I see Dr. Zalamia has her hand up.
I actually just private chatted Dr. Joshi for his email, because I do think there are opportunities for networking and kind of the just-in-time sort of resource sharing that is separate, but certainly an opportunistic opportunity for us to really connect on a different level in terms of needs and fulfilling needs. I actually raised my hand to ask a question, if that's okay. And it was related actually to what Sudo put in the chat as well. And I just wanted to ask, for the greater good, how we might go about increasing our membership and participation from our partners internationally, and how we might be able to sponsor that from an individual perspective or the institutional.
Thoughts on that from other members of the exec committee, or anyone for that matter? These are all just ideas that we don't have all the answers to all of these right now. These are points to consider.
So from an individual perspective, it's quite easy. You can write to the membership committee, or you can just write to Academic Global Surgery at gmail.com and say who you're sponsoring. That's very easy. And when it comes to organizational and institutional sponsorship, we're still working on the details of how that's going to look like for institutions as it is. And so as those SOPs are written, we'd love to have input. And it would be great to be able to brainstorm a little bit of that even further with the membership committee. And if you're interested in more, having more input in that, the membership committee will be one of the committees that you can run for in the November-December election. So it would be fantastic if you would like to join that committee. Please look forward to joining that committee and having some additional input. And I think Chris was going to say something. Go ahead, Chris.
No, I would just echo exactly sort of what you'd said, which it is something that we, as an executive leadership group, but also the membership committee, has discussed regarding sponsorship of LMIC Partners for Membership. The exact sort of the easiest way to go about doing that, and the details of which we are still working on, but please stay tuned. It is something that we're aware of. I really do like Dr. Jayaraman's suggestion of one of the benefits of institutional sponsorship can be that all of your global partners get access or membership within the AAGS. I think that's a really kind of unique idea that we need to explore. Thank you.
Okay. Well, I think we have 4 minutes left. I'm sure nobody will be disappointed if you got that time back, and we'll try our best to stay on time. If Mamta, can you just, I know everybody here has gotten the email from academic surgery, global surgery @gmail.com, but maybe stick it in the chat so that everyone can see that. If they have any further questions, you can reach out to us individually or direct those questions to the general email. Other than that, I want to thank everyone for their time. This is the result of in kind of it's more of a world cloud than a word cloud, but everything that everyone wrote today as to why they're here. So a lot of good things on there. We'll send this out as a part of the committee sort of assembly report. We appreciate everyone's time. Thanks so much for coming, and we look forward to working with each and every one of you going forward. Thank you.
Thank you guys so much for coming. It was wonderful to see everyone here.
Thanks all, guys. Have a great night, morning, afternoon, everything. Bye.
Mamta, you just had to do that survey so you could do the word cloud, right?
Yes, absolutely. We did that word cloud. Did you like it?
Of course. That was the whole point, right?
That was the whole point of those words, was the word cloud.
It was a world cloud.
Yeah. It was a world cloud. We were talking about making, what do you call it? Coffee mugs with it, and then having AAGS on the other side.
Take care, guys. Thank you.
Like we should do this.
Bye. Bye, Manta.
Bye, Mecker. It's so good to see you. Kind to see you.
Likewise.
I will end and start the other. Cool.
Yeah, sounds good.
Thank you, everyone.